Hello everyone, and welcome back to the subspecialty VMR and Happy New Year. I hope you all had a great start. As you know, we have pulmonary critical care today, and for this we also have two guests. Before they can introduce themselves, I will give you a brief introduction of them. First of all, we have Dr. Amos. He will be the case presenter. He is a pulmonary and critical care medicine physician at Mayo Clinic, Rochester. And his major clinical and research interests include sepsis and other outcome-based research in the ICU. His research included observation and experimental research in critical care. He has published over 60 papers, and his diverse publication portfolio includes work in intensive care medicine, clinical informatics, bioinformatics, artificial intelligence, and COVID, and a lot of more. His other areas of interest include improvement in healthcare delivery in underserved areas internationally by providing clinical care and teaching in developing countries such as Cambodia, Haiti, etc. And then we have, as a case discussant, Dr. Gajic. He practices, teaches, and does research in critical care medicine at Mayo Clinic in Rochester. His main goal is improving critical care medicine and outcomes by creating more intelligent and human CU environments. He and his group designed and implemented one of the largest international quality improvement project in critical care, which is called CERTAIN, an acronym for Checklist for Early Recognition and Treatment of Acute Illness and Injury. And so I think that this is also a great start for them to introduce themselves. First of all, Dr. Amos, can you please introduce yourself and also tell us what you like to do outside of medicine and why you chose pulmonary critical care?
Thank you for the invitation. Glad to be here with part of our young learning team. I think the introduction was quite elaborate already. In addition to clinical medicine, I enjoy reading and playing squash. My interest in critical care actually really developed during my early medical school training, and it just grew from there. What fascinates me is the early intervention and forever dynamic clinical picture that develops over a period of time in ICU patients. And what's most gratifying is when they get better. And oftentimes, if they can't get better, then how can we take care of them in their most difficult times? So that has been my short stint, and I will hand it over to Dr. Gajic.
Happy New Year, everyone. It's a privilege to be with the, 5 or 6 now. We have a share screen, so I don't see you all, but with the young people. So that's a privilege for me. I used to do different things. I played in a punk band, and I enjoy skiing and outdoors and wilderness canoeing, a lot of things. But I immensely enjoy critical care medicine, and I don't know. I always liked emergency medicine. Then I did some trauma surgery during the war in my home country, and then when I came with my family after the war to the States, intensive care medicine has just started. And Mayo Clinic had one of the first fellowship in critical care medicine, and that's how I am. So thanks again for the invitation.
Thank you for coming. So, and as you all know, VMR wouldn't be without the help of our amazing friends. First of all, Yasmin, who's doing the teaching points, and Madalena, who's doing the scribe. Could you please introduce yourself?
Sure, I can go first. Hello, everyone. My name is Madalena. You can call me Maddie. I'm a medical student in New York on a research year between my 3rd and 4th year. So I'm on a research year in San Francisco, and really, really excited to be here and learn about pulmonary critical care medicine. So thank you both so much for coming to join us.
Hello, everyone. I am Jasmine. I am a medical graduate from Mexico. Right now, I am in my journey to the step 2 and to looking for rotation. So I'm very happy to be with you. I missed the VMR for this 2 days. I hope you had a great year. So yeah, let's begin.
So, Dr. Amos, could you please start with the case presentation?
Absolutely. So this is going to be a real world scenario, how we are exposed to clinical challenges on an ICU shift. So I'm going to play an ICU fellow, and Dr. Gajic is my ICU consultant. I have just been called from the floor, and there is a code 45, which is also called as code blue, for a patient with syncope and a brief episode of tonic-clonic seizures. The patient is a 60-year-old male with the past history of cerebral palsy. Patient has recently had colectomy for ulcerative colitis and is on parenteral nutrition. And the plan for this patient is to be discharged in the morning. On my primary survey, patient is able to protect the airway. His work of breathing is slightly increased and his oxygen saturation is 85%. On examination, in terms of the cardiovascular status of the patient, he's tachycardic with heart rate of 145, with systolic blood pressure in the 60s, and he appears mottled. He is awake, verbal, but is I'm unable to understand a lot of things that patient is trying to say. Clinical examination in terms of his neurological status is rather non-focal. Abdomen appears distended with no peritoneal signs. And I do a quick bedside ultrasound for the patients. I don't see a lot of B lines on the ultrasound, no cardiac tamponade. The left ventricle appears a little hyperdynamic with an enlarged right ventricle and a little free fluid in the abdomen. And point of care labs show lactate, which is elevated to 10.8. And his oxygen PaO2 is 60 with PaCO2 40, pH is 7.3, hematocrit is 28, which is stable from morning, potassium is 3.8, white cell count was 18,000 with hemoglobin at 9 and creatinine 1.4. Dr. Gajic, any questions, any additional history or information that I can provide to you at this time?
First, I'm very fortunate to was working with you, so he looks like he's in a safe hands because you very rapidly went through how we need to assess someone who is just about to die or get disabled from some catastrophic condition. So this ABCD approach has started with a trauma, with ATLS being the first formal program of quality improvement for trauma patients, and then something similar exists for ACLS for cardiac emergencies, and we extended this for the for any emergency. So I see that he protects the airway. There is some increase of work of breathing, and is he on any oxygen with this 85%, or is it like?
So this was on room air, and then we hooked him up to some supplemental oxygen. His oxygen came up to 90% after 4 liters.
Okay, and what worries me the most, obviously, his systolic blood pressure is 60, and he's mottled. And on a monitor, I assume this. Can you see if it is a sinus? Do you see sinus, or it's a arrhythmia, or you can't tell?
It's difficult to tell, and the room, of course, is quite chaotic on the floor. And I'm hoping to get him to a safer place, to the ICU soonish.
So just a small teaching point. Obviously, the when you have a tachycardia to 150, around 150, it could be arrhythmia. It could be sinus tachycardia, and if it was arrhythmia, let's say atrial flutter, potentially an emergent intervention would need to be now to cardiovert the patient who is, if we think that the arrhythmia is causing the hypotension and shock. The context doesn't look like that, and I would for the moment hold off the until we would have an ECG and prove that it is arrhythmia. This could be, even if arrhythmia could be secondary to something else in a context of patient who's been hospitalized after surgery. So hold that thought, but I don't believe. So we as we go through ABCDEs, we try to immediately act upon, and we acted with adding supplemental oxygen with some improvement, but still work of breathing. So on the floor, we cannot do much. We have to get back to the intensive care very soon. And then for mottling and hypotension and tachycardia, one thing was cardioversion if it thought it was arrhythmia, but it's not, at first not practical down on the general ward. And a second, we are not sure that what is the chicken and the egg here. I guess you already have the ultrasound, but we usually start with some fluid bolus. Even in cardiogenic shock, it's unlikely the moment you see the patient that heart is stretched enough to oppose the actin and myosin myofibrils to the best way. So I think 500 of Ringer Lactate or something would be reasonable. What do you think, Amos? Just as we are moving through, let something start. Does he have IV access?
He does have IV access, and the fluid bolus has begun.
Okay, and what IV access does he have?
He has a very tenuous 20 gauge IV cannula.
Okay, and how was he getting the CPN?
Oh, so he did have a PICC line, but that is a single lumen PICC line.
Okay, so in any case, we need another IV access. You can start with IV bolus, and then in such an emergency, we should have an IO kit ready. Intraosseous kit is absolutely essential part piece. So the only two interventions that one need to know is a 2-hand bag and mask and IO intraossal as any resident. Everything else can wait for a little while, but these two are critical interventions of intensive care that any hospital physician would need to be, or provider would need to be familiar with. So let's make sure that we have IO kit at the bedside. If you can find quickly another larger IV, we will have to put the IO. It is actually just insertion itself is not painful. What is painful is to give something to that IO. So please get some 2% lidocaine, so we could flush first with the lidocaine. So if we have to infuse any medications, we can do like that. So lidocaine and IO kit at the bedside, please, Amos. And D, is he, so you said he's cerebral palsy and he's somewhat, we don't know his baseline, I assume, but in any case, he does respond to your verbal. When you try talking to him, he did mouth. So there is some, at least he's verbal responsive. So rather than Glasgow Coma Scale, I think AVPU is the way, or AVPUD is the way how we assess the patient. So awake, verbal, pain responsive, unresponsive, and then D would be for delirium, which is more a qualitative change in mental state. And with his mumbling, we cannot really say if he's delirious or not, but with systolic blood pressure of 60, difficult to say. You say that he doesn't have peritoneal signs, but abdomen is distended. Is he tender? Does he grimace when you touch him?
So I think it is just a post-operative pain, nothing very exquisite.
Okay. And then you did a quick ultrasound. There were no B lines, so we think immediately probably safe to get some fluid. No tamponade, that's good to know. Hyperdynamic LV, so another reason maybe to give. But you said that there is an enlarged RV, so I would probably want you to show me how it looks, and we would need to do a formal echo when the patient comes to the intensive care unit. And you said there is some free abdominal fluid, which is difficult to if it was trauma or something, that would be important information, but he could be bleeding, he could have a just post-operative fluid collection, he could have an abscess. So I'm just noting that, but if you could see it on your pocket ultrasound, that probably is sizable amount of fluid in that abdomen. And then lactate, point of care 10, he had a seizure, brief clonic tonic seizure, so it could be either shock or just result from the seizure. With a hyperactivity and seizures, you can have a local production in the muscles of lactate. So I'm much more worried about mottling than the lactate, but when together lactate and mottling, it looks that this is probably seizure is from shock and hypotension rather than hypotension and shock being from the seizure, given your astute observation that he has mottled knees. Then oxygen looks, not that low actually on some oxygen. CO2 looks normal. pH is 7.3. So there is some metabolic acidosis there, probably lactate. Hematocrit is 28 on a gas, so it could be still bleeding, just very early bleeding that hematocrit didn't have a chance before we gave fluid, so we have to follow it up. But it's you didn't tell me, is he warm or cold when you touched him? Extremities.
So he feels a little cold and clammy on the peripheral touch. So probably not perfusing very well.
So the and fever, temperature,
afebrile.
Yeah. So in any case the colder extremities would point out for hypovolemic or cardiogenic or obstructive shock or septic shock with decreased perfusion, with some involvement of the heart. We have this enlarged RV also that could point to either cardiogenic or obstructive shock. So we'll take a note of the fact that he's not warm, which doesn't exclude distributive shock, but it is important. And I see here leukocytosis 10 days after surgery, a little bit too much. So it could be stress from a heart attack. It could be obviously sepsis. And this morning creatinine was I guess normal for him. Okay, I guess we need to get him as soon as possible up to the intensive care unit so we could start some advanced respiratory support, because that oxygen is not going to work for his increased work of breathing. Fluid bolus is going, and then IO we can place up there if needed, and then we'll continue with a plan by systems to evaluate in more deeply. Okay, and I want to see the ultrasound images if you have, and the quick portable chest X-ray and the EKG, given this arrhythmia. So EKG, so fluid, IO at the bedside, oxygen. As soon as he comes in the ICU, EKG, so we could see if this is arrhythmia or not, if there is some ischemia. I want to see the ultrasound myself, if you can show me once more when he's up there. And I think for the moment that would be the first things, and then chest X-ray I think would be reasonable to do, just in case that we are missing something on the ultrasound.
So while the team was preparing to call for a rapid response, they had also made a few phone calls. So the chest X-ray was done while we were downstairs, and this is what it looks like.
Okay, so you told me, so I think he still has this IJ in there, maybe when we are looking very quickly. So that's because he was on CPN, that maybe. So there is, when we look at the portable X-ray in intensive care, the first thing we do is appliances. So there is no ET tube, there is central line in a right IJ probably, but it looks like tip is in superior vena cava, which is good. We have a central access that we can get, that we could add the rather than IO, that we could add vasopressors if needed. There's some ECG leads, monitor leads there. The next thing after the airway and appliances, we look at the bone and joints. I don't see any free air or something marked on his outside of the chest. C is cardiac. Cardiac shadow looks pretty normal. It's about half of the chest, which you would expect. I'm not sure that I could tell anything about the shape of the heart. After the C cardiac, we do D, diaphragms, so there are no effusions. Diaphragms are visible, and they are the same size, not pulled or pushed. E is kind of equal volumes. We don't see any difference in volumes of the lungs. And then F is a fine detail. So even with the imagination, it's difficult to find any pulmonary edema. So I think with the B lines being absent and this chest X-ray, I don't see really something to explain hypoxemia in a lung parenchyma, at least on the X-ray and the ultrasound. And do you have ECG or? Okay. And I assume it's a surgical admission, so you don't have a baseline ECG. That's the first one they've done.
So this is the first EKG during the hospitalization.
Yeah, that's the. So what I can see here is sinus rhythm, sinus tachycardia, but they're P waves. Nothing up here. And then with regards to QRSs, I see like a little wider and double spiked R waves in a V2 and V3, which usually suggest bundle branch block, maybe chronic, but it's on the right side. So if someone is to connect, I want to see that ultrasound, it could mean that right side of the heart, right side of the heart is in quote suffering either chronically or acutely. And then going to ST changes, there is tiny ST depression maybe in V5, 4, 6, hard to make out. And then with imagination, not really, there's no ST elevation. I guess I was looking in level 3, but nothing to suggest a heart attack other than the right ventricular infarction. We're presenting as right bundle. That would be very rare. We know that the left, the LAD occlusion could present sometimes with left bundle branch block, not only with ST elevation. And I'm not sure what to make out. Things like acute RV failure, acute on chronic RV failure, or pulmonary embolism with acute heart failure would come to my mind.
And for whatever it is worth, when I asked for the patient, he said there is no, or at least in the chart, there was no significant past cardiac history.
Okay. And so you did that. Let's see if you can put, so the, I assume you couldn't get the subcostal views because of his distension or ileus.
It was challenging because of his abdomen and the scar, so I couldn't press on the subxiphoid region.
Yeah, other than if the patient is not post-surgical, we always, and maybe the only view we ever need for cardiac view is a subcostal view, the easiest to get, especially in a patient who are on a ventilator, for example, because the diaphragm is pushing the heart, and it's usually through the liver window is the easiest to get the others. But in post-surgical patients, post-abdominal surgery, it's very challenging. So we have to go with a cardiac. So that looks like a right parasternal. Is that something like that? Can you play it?
Yep. Let me see. Having some difficulty to play this.
That's okay. If I on a still image, so this like the LV is small, and you said it's hyperdynamic. It's pretty. There's some concentric hypertrophy of the muscle, if anything, chronic. There is minimal calcification of the aorta. It's hard to say if it's stenotic or anything, and that RV is way too big for something you would want to see on a right parasternal. And I assume you flip the probe towards the left shoulder to get a short parasternal axis. So the this left ventricle should be down there. Can you point on this? Okay, so that's our right ventricular. Okay, and then down left. So this is kind of pretty classical to what we call like a D-shaped left ventricle. The RV is so enlarged. So please stop that fluid. I think 500 is plenty, because any further fluid can make this right ventricle distend to the point of collapse and arrest. So if you can stop the fluid, please, and we need to support him with is his blood pressure is still low after that fluid, I assume. So please start some norepinephrine immediately.
So we have connected the norepinephrine.
Start with 0.1 per kilogram per microgram per kilogram per minute, and then keep going up. There is no limit to norepinephrine. So just we will probably have to do with this some arterial line when able, because the blood pressure may not be as accurate with the non-invasive, and it's going to bother him measuring all the time. Okay, so you started some norepinephrine, and
yeah. So quickly, after stopping the fluid, we started on norepinephrine, but his blood pressure was still not stable, so we added vasopressin and then epinephrine as well. Because there was suspicion for ongoing infection, we were not sure, so we started him on empiric antibiotics, and for oxygenation, we put him on high flow nasal cannula. And based on the ultrasound findings, we discussed about IV heparin as well.
And Justin, I assume he was getting prophylaxis on surgical floor postoperatively, low molecular weight heparin.
He was.
Heparin. Okay, that's still, it diminishes the chance for pulmonary embolism, but obviously patient 10 days after surgery with sudden shock, the pulmonary embolism is high on a very high suspicion. And I think we need to call the surgeons and make sure that, because I don't know if he's stable to go anywhere, would they object if we would give him like a alteplase, like a TPA, because if this is pulmonary embolism, it is massive, empirically without imaging. I'm just asking if you can, did you get a chance? I think they need to know that their patient is with us, and we don't have a signs of bleeding now, but they know what they're doing there. So I would just ask if this is, if they would be okay, or they would want us to prove the pulmonary embolism before any thrombolytics.
So the surgeons have full trust in our assessment, and they think the ICU team should do whatever it is necessary.
Needed.
Yeah.
Okay.
No reservations from surgical perspective.
So they would be okay to give. So with this amount, and I see you had to double up the vasopressin. We usually use like a replacement dose of 0.04. It is okay to titrate and get some more, because it works in severe acidosis a little bit better than catecholamines. So someone who is on a quite industrial dose of norepinephrine and some epinephrine already in desperate attempt going to 0.08 per kilo per minute is fine of vasopressin. So he's 90% saturating, respiratory rate is 30, heart rate is 130 now, at least you get down, and it's sinus, so it's not arrhythmia, and he's mean around 60. So is he awake? So
yeah, he's still awake, but mumbling I can't understand very much. And while we were interacting, I wanted to just run a few ideas through you, and if you could help me run through this mind map in terms of our approach for him, that'll be very helpful.
Okay, I think that's really so. That obviously hypertension is the presenting feature for him, and there was a seizure too, and I think the shock and sepsis come up very high, but shock could be from something else other than especially with the ultrasound findings that we've seen. So vasopressor, you start inotropes. I think epinephrine has some inotropic activity. We could, if is he still mottled, or is he a little bit better, or?
The color is getting slightly a little bit better after all the medication that he's getting.
So adding inotropes such as dobutamine or milrinone is possible, but I think we can wait later. At this time, the blood pressure or coronary perfusion pressure takes the priority to keep that right ventricle from arresting. So I think we just should go with epinephrine, which has both some inotropic activity and norepinephrine too. And but the key is to keep the coronaries perfused. So I think antibiotics, given leukocytosis and post-surgical state, and this could be sepsis and some chronic RV failure, it's for all I know. So antibiotics are definitely, and something for nosocomial. So what antibiotics are you thinking?
Because he's been in the hospital for a little bit, I gave him vancomycin and cefepime to cover for MRSA.
I think we should add something for anaerobes because they had a colonic suturing, so there could be a leak, and you've seen some fluid, so definitely add metronidazole.
That's a great idea. Added.
And then make sure to call the pharmacist, because we need to give it like within an hour, and if we just put the orders, it will not come in 2 hours. So please call, if you can have someone call the pharmacist very quickly, so that they can, we are fortunate here at Mayo Clinic, we have pharmacists in the intensive care unit during the day, so they can make a magic and get these antibiotics to the bedside. Then epinephrine anaphylaxis, he didn't get anything down there before this happened all of a sudden. It was not like after some medication.
No,
so
nothing out of the ordinary, nothing.
Bleeding, GI bleeding, we don't have any melena, but bleeding in the abdomen is still possible, although the first hematocrit didn't show it, and he's really doesn't seem to be hypovolemic based on that RV, so I don't think we need a transfusion at this time. Acute abdomen, it's difficult to say, but surgeons are on board. And do they have any suspicion for a leak or something?
Suspicion is pretty low. He's been actually recovering very well. The plan was to send him home tomorrow.
Yeah, that's what they say. I think if we are able to get him to some imaging, in addition to contrast imaging to exclude pulmonary embolism, he needs to go through the abdomen. So CT body, if we are able to do it. I don't think he's safe now, but we would have to look for it because it could still be leak, anastomotic leak. Tachyarrhythmia, no. Coronary syndrome, I guess we don't have anything other than non-specific T waves. So troponin is reasonable to check. I'm not sure what we'll make out of it. It will be elevated no matter what the reason of this shock is, but we could look for delta. It doesn't look like something that would need a angiogram at this point. It would be very rare to have such an isolated RV infarction, hospital acquired. So that's a lot. Pulmonary embolism comes there, which is a very high on our suspicion. He's already on heparin. You started him, and thank you. But the question is this enough, or we would, with this industrial doses of pressure, this is obviously, if it is pulmonary embolism, it is massive pulmonary embolism with shock, which we would need to consider thrombolytics on an emergent base, even potentially without proof. Aortic dissection, I don't think you get that in a hospital, so that will be very unlikely. And then we didn't really see anything on a CT or the ultrasound to point that. But CT should, if we can get him to CT angiogram, that would exclude dissection as well. No tamponade, you looked, there was no valve or septum rupture, but we should get a formal echo. I trust your skills, but we should have a formal reading of this just to make sure we don't miss anything. And so we went through different, let's go, I think, he's at the moment stable. At least you have a mean arterial pressure and he's awake. We don't need to do intubation. We'll see, can we safely get him for a CT or start empiric treatment? But let's go through the systems very quickly. If you have our rounding checklist. Very quickly.
I do have a rounding checklist, but with his such tenuous state, I was wondering, if we need to intubate him, and if we're going to intubate him, what should we do? Do we need to find out a little bit more information about him, or a combination of these things? It's a little bit tricky, and the nurses are also not comfortable with us just not doing a lot for him.
Yeah, I mean, we are doing a lot. So he's on 3 pressors. The question is, sometimes by doing too much, we could make things worse. So, we should, work with our nursing colleagues. Just we are there. So I'm coming in a room too, to make sure that he's safe. And I see that there is a woman there that, is it, maybe, did you introduce, is it his caregiver or a wife, or do we know anything about him?
That's his wife.
That's his wife. So I'm very, it's interesting that we went through a lot of things, kind of not thinking of him as a person, to be honest. And I think while even in this emergency, it would be very reasonable to have, while we are doing this, and we usually like to give our family member, or even do it with the patient, what we call is get to know me board. So before we would do this on these 4, and we can talk about intubation, but at this point he's still talking, he's protecting the airway. I think with this amount of shock, intubation could be could pose a life danger. So let's step back and maybe see what that get to know me board show, to be honest with you, because here these choices, ketamine versus propofol. It is true that propofol has more cardiodepressive and more vasodilatory action in normal patients, but in someone with shock, profound shock like this, I don't think there is any difference between ketamine and etomidate. And I see you already looked it up. So etomidate,
that was something of interest. I was wondering if I were to tell my nursing colleagues to pull up any medication, if we should go the etomidate route versus ketamine versus propofol. So that was just a very quick review of our choice of medications for him.
So yeah, okay. While the wife does this get to know me board, we can discuss briefly. So I'm scared to death of intubating him, Amos. I just have to tell you that. Okay. So the in tube study, so intubation in intensive care is much different than intubation in the operating room. And someone in profound shock, particularly in a cardiogenic shock, or God forbid, obstructive shock, such from massive pulmonary embolism, has a very high risk of cardiac arrest during intubation, even with no sedation, just from switching from negative to positive pressure breathing, just with bag and mask ventilation. So I think that, so we have to be very careful. In tube study that was published, and Dr. Bauer from our institution participated, I think 2 years ago in JAMA, large prospective study of intubations in intensive care unit. 1 in 3 patients develop severe shock and hypotensive after intubation. And that's just any intensive care patient. So hemodynamically difficult airway is much more important to me than the anatomically difficult airway. With a glide scope, video laryngoscopy, bougie, bronchoscopy, we all, as a pulmonary critical care physician, we are skilled in all of these. There is always a way to obtain, to overcome the anatomically difficult airway. And we have our anesthesiology colleagues as backup if we have. Do you see, can he bite his upper lip?
It was very difficult to assess his airway, unable to follow the commands really, while I was chatting with the wife to help us fill up the board. And for the first time, I found out his name, Ben Anderson. Okay, Ben. So if he could, just being able to do the upper to bite the upper lip excludes anatomically difficult airway with a good certainty of all the tests. So rather than these, that for some board questions you can do Malampati and other things, but it's in practical, the only thing you can do is the so-called upper lip. That's the quickest way to assess someone. Unfortunately, we couldn't do it in this. And then mouth opening, I guess, would be, but I'm not worried about it in him. To be honest with you, I will use the glide scope anyway if we have to intubate, but I'm scared to death of intubating him because I think the risk of severe hypotension, because he's already on max pressors and cardiac arrest and CPR is huge. So if possible, I would think of even VA ECMO cannulations before intubating someone for him. So
when we are at it, while I think, can you just ask one of the nurses to call ECMO pager, because it could be, at least we have it takes some time to assemble ECMO team. It takes them 30 minutes to come at the bedside, but I think we should probably notify them about the patient. So just say patient in profound shock on 3 pressors, possible pulmonary embolism. We'll see if we are going to give thrombolytics, but they should be on standby at least.
So we updated the ECMO team and they're aware. They are actually not in the hospital, not in the Methodist hospital. So they're coming in from St. Mary's. So they'll be there in 15 minutes.
Okay, wonderful. So that's good.
In the meantime, the wife helped us to fill the Get to Know Me board for Mr. Anderson.
This helps me just to take, while we are thinking of what to do. Should we start thrombolytic empirically without imaging? Should we try to get to the imaging, maybe if you accompany the patient? This is a good break. So I see here his favorite book is IQ of 63, So What? By himself. That's fascinating. Did you talk a little bit to his wife about this? This is all fascinating.
Yeah, very fascinating personality. So this is he's a high achiever, despite the low calculated IQ. And this book is something that he's actually very proud of. And he actually is one of the leaders who's supporting people with cerebral palsy as well.
So this is absolutely fascinating, Amos and I have actually, and you'll have a chance, all of you, to see the case report. Yeah. So the Amos and I have actually, fellow and I have been in the situation with this patient, and suddenly he came alive in front of us instead of like disabled patient with paralysis and shock, and we actually could come back to the patient. And as I touched him, holding his hand, and asked about his book, literally his heart rate and blood pressure improved, his respiratory rate and heart rate improved. I think we have some on the next slide, Amos. I think we do have something. Okay, so as we considered him as a human being and started talking to him rather than over him, his anxiety, which was obviously a huge part of this when you have such a profound shock contributing, his heart rate and respiratory rate decreased to the point that it was safe that with a fellow escort he goes down without intubation to the CT scanner. And what do you see here, Amos, on that CAT scan?
So on this limited windows, I can see that looks like a large clot burden in bilateral right and left main pulmonary arteries, probably a saddle embolus which kind of broke and has gone to both the sides now. What are you starting? What are we going to give him? So I'm still debating about a full dose versus a half dose. He's already on IV heparin. I was thinking about giving him alteplase. And then if he needs, the problem is also with the full dose, if this doesn't work and we have to put him on ECMO, it's going to be a bloodbath. Sorry to say that with a full dose. So there is really no good data, but there is some sub analysis of MOPED study that show that 50 milligrams alteplase may be as effective as 100 milligrams and potentially with the lower side effects of bleeding, in particular if he would place ECMO cannula. So I agree with starting the 50 of alteplase. And while we're here, let's quickly do a system-based plan. So the entire nursing team and our other colleagues are also on board. What do you think about that? So first, he's not delirious. Actually, he seems that we thought we thought we didn't even consider him as human being, looking at the ultrasound and other things. And after we looked at the Get to Know Me board, we realized that he's actually neither in pain and he doesn't have delirium. So I guess we just need to hold his hand and,
help explain him that he's safe here, that he probably has a big clot and he's gonna feel better in no time. I think if we can encourage him, we can avoid ECMO. So just encouragement, no medications. Cardiovascular, so you're on 3 pressors now, you're starting TPA, and we have ECMO team on standby. So thrombolytic, we'll try weaning pressors as possible. I don't think he needs any inotrope at this time, but we can consider if he's still cold or his urine output is very low to improve perfusion, but not at this time. I think epinephrine is enough. Respiratory, so I think this high flow nasal cannula is the best we can do because he's holding his saturations, and positive pressure could precipitate shock, so I wouldn't do CPAP or BiPAP. And then intubation we already discussed, but if we are to do intubation, we have to be prepared for CPR or ECMO. To be honest with you, I would first place ECMO cannulas while he's on high flow cannula before we would intubate. He would not be safe. Kidneys, so we have to put a Foley, I guess, to find out. Did he have any urine in a bladder on that ultrasound when you've done?
A small amount. We put in a Foley catheter. He's making 30 ml per kg for the last 3 hours.
Okay, so that's okay. That means that he's, so he's some, 0.5 per kilo per. I think he's making urine. That's good enough for me. So I will do nothing else. We avoid nephrotoxins. So we shouldn't continue vancomycin, I guess, after the first dose, because it is somewhat nephrotoxic. Cefepime, flagyl should be okay. GI, he should be NPO now. Glucose was okay on that test set. Outside prophylaxis, I think I don't know if he's on it, but I don't think it matters in the moment. We have to hold off any feeding in a case we intubate. And then we will have a CT. CT didn't show any leak, CT abdomen, correct? Okay, so I guess we'll see when after this shock is over with. Antimicrobials, if he's still white cell count, I don't know if he can have 2 things, but probably this is just pulmonary embolism, and I like the idea that you want to DC the antibiotics. So the fact that we started an hour ago doesn't mean that we should continue them now. So I think it's perfectly fine to stop it. Skin, I guess his wound is okay that we looked post, it's healed well, so nothing to do there. And there is nothing else on the skin, correct? No rashes, and mottling has resolved, I assume, now with these pressors.
Much better.
Medication, so he's TPA 50 milligrams. We will hold off the heparin until TPA infusion goes, and we'll check the APTT and we'll restart heparin after once we get to a lower levels to prevent double effect of the heparin and TPA. Antibiotics we stopped. I don't know if he's getting any pressors, so we should probably start weaning epinephrine first, probably, in my opinion, then vasopressin back to 0.04, then we could go with norepinephrine. We don't know the human data. In animal studies, vasopressin and norepinephrine seem to have more pronounced vasoconstriction of the systemic circulation than pulmonary. So we favor in a pulmonary hypertension, for example, patients, we like to give norepinephrine and vasopressin rather than other medications, phenylephrine, that would potentially cause more pulmonary vasoconstriction and make afterload of this RV higher. One thing we forgot, and that's something that we could consider as an adjunct to cardiovascular medication, would be inhaled vasodilators. And if we are if this doesn't work while waiting for ECMO, or if he's to get any worse, although expensive, I would start him on inhaled nitric oxide just with a face mask on the top of the high flow to do that, or maybe with a CPAP circuit, and then continue it during the ECMO cannulations. So we do that in patients who are already intubated, but it is something that we could do in non-intubated patients if available in your hospital. Inhaled prostaglandin is possible too, prostacyclin, not as effective as nitric oxide probably for hemodynamic, but something to consider. So definitely put on a TPA by heart, put question inhaled NO if needed, and ECMO on a cardiovascular. So inhaled NO. So you see, by double checking, by thinking of medications, it came to us that there was one other approach to decrease RV afterload that neither you or I thought at the moment, but now as we systematically review the medications, it came to our notice that there are other ways to address the hemodynamic compromise, and I think this would make ECMO cannulation and eventual intubation safer if we would have him not only treated with vasopressors, but also with inhaled nitric oxide. It's used in babies, for example, or in congenital heart disease patients, adults, quite often for intubation and extubation to keep the RV afterload as low as possible to prevent cardiac arrest. Physical therapy, I think today we cannot do it, but we should get him back to his baseline. And my understanding is from his wife, he's able to walk, although with cerebral palsy, with a cane, I assume.
Yeah, he's ambulatory at baseline.
Yeah, that's wonderful. And then family is present, his wife is there, and we didn't even ask that much about the intubation, but from what we could formally address the goals of care, he was full code, so we proceeded with everything. But just in case, if we should discuss with the patient and the family, he's 60, and ECMO, VA ECMO is a reasonable option for someone like him, because it will be just a short term for shock. It's not like a VV ECMO for COVID for like 2, 3, 4 weeks, which I wouldn't necessarily recommend for someone like him. But I think it's reasonable if they don't have any objections to proceed with VA ECMO if we can afford it, if they don't have any objections to that. Did you talk to the wife? And I don't know if he can understand at this point, but we should certainly have wife's consent.
So the family has been extremely supportive. The wife is very understanding, and her medical literacy is, I think, above average. So she understands all the life-saving measures that are necessary for him, that are required, and is willing for a short course of ECMO if necessary.
Good. Although the poor patient he may not fully be able to fully grasp the situation. We need to inform him, similar to, the word is assent. So we should come and tell him, just in case that this doesn't work, we hope it does, we will put you on a replacement of the heart and lung with a machine that is called ECMO. You would get 2 large kind of like catheters into your big veins and artery in the groin. And I hope that's okay with you. Okay. Next, what do we have? Do we have anything else to share on this
I just
case?
want to share the case resolution in the next 24 hours.
Okay, so you started him with TPA, and then we were able to get him off all pressors within 24 hours, and luckily he didn't bleed or need ECMO. So I remember actually he gave us tomorrow that book, and I read it in a day. It's a fantastic book, strongly recommended for everyone who is listening this. But it's very, he grew up as a patient with cerebral palsy before we knew as much about that illness. So he was like in a school for special ed with patients with different cognitive problems, although his IQ was way above average. However, the school and the way how he went to school, it was not necessarily very useful. So when he went to become 18 to apply for college, his IQ was 63. His grandfather always believed in him. In the summer, he would spend some time with his grandfather, and despite of him talking funny and not being able to walk properly, and both walking and talking funny, his grandfather would put him like to help him with lawnmower, with everything. And he instilled in his grandson confidence, which really helped him. So he didn't give up. He started volunteering for the church. He kept preparing. And at the age of 24, he passed the college exam, went to the college, and finished, among other things, a master's degree. And he teaches all around the country how to, not only disabled people, how to act for themselves, but also people and healthcare workers who are not disabled, how to understand patients and people with disabilities. And it's a fantastic, the one thing that is good in the United States is this so-called American for Disabilities Act. That's one of there are a lot of wrong things in any country, but this is one of the best things that has happened. And it's you can look at it. There's some Netflix documentary. It's very fun. It's fascinating story of how this actually came. It wasn't that someone gave it to patients with disability. It was an advocacy, political action by patients with disability who did absolutely amazing things until they got American for Disabilities Act through legislature to be an act, and it's absolutely fantastic. So I just want to finish this on a small story, which was at the moment that afternoon after he was getting better from shock. So I came back to the patient, and he wanted to tell me something, and I just couldn't understand fully his accent, but slowly I was getting into it. So fellow and we are listening to him, and he's telling us a story that was the same afternoon about one of the advocates for American for Disability Act, who was his friend, who had phocomelia from thalidomide, if anyone remembers. So phocomelia is basically he didn't have upper extremities. And it's all of this is in the case report. So I strongly recommend you to read it. I have more than 400 papers, but this is my favorite because the patient is the senior author. That's why we actually share this story with everyone publicly and his name, because this has been published and he actually likes us to do this. So this colleague of his, that the story that he's telling us is how the day before in a hotel, the day before signing the declaration of this Americans for Disability Act, ADA, he was to call his colleague was to call his home. So he reached out with his other leg into his buggies to grab a coin to put in a payphone and to call his family, grab the receiver with his leg and talk. So he's explaining that to us, me and a fellow. And poor fellow doesn't know what the payphone is, let alone the explanation of the whole thing. So that afternoon, his mental state was such to explain me the story about his colleague and one of the advocates for Americans for Disability Act, showing, reaching to his, he has only lower extremities, taking a quarter from his pants, putting it in a payphone and calling his family, holding this receiver with his leg in a public space in a hotel, which is just a fantastic story. And if there are any, I think we've talked a lot, so especially me. Amos, do you have anything else to add to this story from your standpoint?
No, this is, I think, very fascinating and one of my favorite patients to know more in detail than just a patient. And this brings us back to our introductions, that why we decided to do ICU, and this is really in flash, to know patients and to help them in their most difficult times of their life. So I think I'll stop talking, and I think at the end of 60 minutes, let's see if any audience or our other colleagues have any questions.
You can unshare screen. If we will send to Problem Solvers, we have the references for everything we talked. So we could have this paper and other, it is free to read. So it's like open access. So so we could share the references that we talked about, including the whole case report with the audience, because the case report actually has, the patient wrote half of it, so you could see his side of the story, and he became one of the big advocates of getting so-called get to know me boards across hospitals in the United States based on this experience. But if you guys have any questions.
So first of all, Dr. Gajic and Dr. Amos, thank you so much for coming. It was such an amazing case and also a brilliant story. I guess because we're out of time, Yasmin, who did the teaching points, would like to sum up the most important things she learned through the session. And I also wanted to say thank you to Maddie, who also did amazing scribing. Okay, Yasmin.
Of course. Thank you for this amazing case, Dr. Amos, and teaching Dr. Gajic. It was really nurturing everything the